Hi, everyone. I'm Dr. Pamela Schaff, and I'm the director of the HEAL program here at Keck School of Medicine. And I'm pleased to welcome you to our third art show of the 2018-19 year. And today we are really lucky to have Elena Johnson here. Ted will tell us more about her and her work, and she will tell us a lot about her and her work. But I wanted to just remind us that this endeavor here in the gallery is part of our HEAL's White Gallery mission to align the work of artist patients with our medical school core curriculum and to foster enhanced understanding between patients and future health professionals. So we welcome all of our students who are here as well as faculty and staff. And I will turn the program over to Ted Meyer, our artist in residence. I also want to introduce Dr. Elizabeth Ortiz, who is a rheumatologist here at USC, and she's also in charge of the Year 2 musculoskeletal system. So she's responsible for what the students are learning right now that aligns with the work of Elena.
Hi, everybody, and thank you for coming out in the rain. So before I get to them, as always, I'm going to ask you a couple questions because you guys all have to pick your specialty so you know what you're in for here. How many people in the country do you think have rheumatoid arthritis? Anybody have a guess?
10 million.
Less, 1.3 million. 41 people in every 100,000. But still, that lands up costing each person almost $6,000 a year in care, one way or another, drugs, and $7.5 billion worth of medical costs a year. So there's money in there for you guys if you want it. We're going to start with Elena. I put out a call for people who did work about musculoskeletal, and several people in the LA community pointed me in her direction. We were, I believe, friends on Facebook already, but I'm not sure we had actually met. And so she does a lot of work about her illness. So why don't you tell us first what you were doing art-wise before you started getting symptoms. Tell us a little bit about when your symptoms started showing up and how that incorporated into your artwork.
Okay. Well, I didn't start having symptoms of RA until I was in my 30s. So the art I made prior I was a housewife, with 3 kids, and I did domestic things and crafty kind of art and flower arranging. So I went back to school after I had my diagnosis. And I was very attracted to work about the body, obviously, because mine was changing rapidly. And before I graduated with my undergraduate degree, my hips were gone and I was walking like a penguin, ended up graduating in a wheelchair. But I was determined to get through it, and I did. So most of my professional art just has humans in it, and it is about the body, and specific works are about having the disease of rheumatoid arthritis. There's several examples in the room here.
We'll go through the art in a little bit.
Okay.
So, doctor, how did you choose the specialty? What interested you about it that might interest some of the students here?
Well, I first got exposed to rheumatology as a student in my 3rd year internal medicine rotation. When you're on rotation as the student, you get given the quote-unquote interesting case. And so I had a vasculitis patient, and I just thought it was really interesting. I also noticed how not many of the other doctors on my team understood the condition. And so when again, as the student, you had to give a presentation to the team. I was noticing that people were taking notes and didn't really know what the condition was. And once you kind of get turned on to a field, all of a sudden that's all you can see. And so every rotation from that point on, my differential had a bunch of rheumatology diagnosis. I thought everyone had lupus, rheumatoid arthritis, vasculitis, and I just really enjoyed it. I enjoyed the patients. autoimmune conditions in general tend to affect more women than men, and I liked that. I enjoyed being able to follow patients on a long term and really get to know them, get to know their families. And to say it drew me to the field, probably not, but one thing I've learned to really appreciate from the field is kind of being able to stand by someone when they're going through a really life-changing time. And I'm sure we'll get into later how much we can and can't do for those people, but to just be able to stand next to someone and say, I'm here for you and I will attend to you while we go through this together is something I really enjoy.
So one of the things we've talked about with other doctors is certain illnesses, you're with people for a long time. I guess some of your patients, you could be with them, like with her, if she's diagnosed at 30, if the timing's right, be with her for 30 or 40 years. Mm-hmm. So is that one of the things you like about this? Like you really get to know people.
You definitely get to know people. I have been in practice for 8 years, so I have patients I've seen for 8 years. Some of my colleagues who've been in practice for 30 plus years have patients that they've had that entire time. And it is something I enjoy, but it's also something it's a challenge. It's a challenge to be there because we have many patients that we're there for, and that's something that I've learned as an attending physician kind of in my practice, how to be there for each and every person on this kind of long-term journey. I watched previous discussions, and I know for the cardiology that that particular patient had something that was cured. And in my field, I'm trying to think, there's not much that I can cure.
So let's get back to you and your art. So first, when you were told you had this, what were your first symptoms that brought you to the doctor? And then what do you notice? Like obviously, looking your hands, it's obvious. You walk sort of like I do with a little oddness to your gait. Little skip. So how is it first looking at your own body and watching the changes and then incorporating that into your art, but also the way, I know your daughter's here, and maybe how you think other people see you as your body's changing?
Well, what's really strange is because my family knew me before when I had no obvious problems, and I was strong and right. I was super mom. So they really, they notice everything. Where, like coworkers, they don't really notice a lot. And I guess I've gotten pretty good at adapting and camouflaging because I like working and I like making art. One of my doctors told me I was a rarity. I was like, really? I guess a lot of people just want to lay down and give up, which I can understand. I have days like that too. But yeah, I think the hardest thing, because I've had replacements which have been amazing, and people, decades ago didn't have those options. So I've had bilateral hip replacement, both knees, my right shoulder, and this hand. They were all lifesavers, and they were great, except for the hand. When you get down to those tiny little bones with all the things going on, yeah, it's not as successful. But I think with RA, the thing that makes it hard to keep going is, of course, the pain and the fatigue, because no longer does it take you a half hour to get ready. It takes you an hour and a half, So you just have to try to change your lifestyle and adapt, and that's super important. But yeah.
How about holding paintbrushes?
I really haven't had a problem with that. It's more with writing where I have to put pressure. But the paintbrush, I still can manipulate. And I like to drop paint a lot, so I don't have to deal with that tightness of the paintbrush. But I teach drawing and life drawing, so when I'm giving my demos. Sometimes I'm starting to have a hard time, but my students are great. They're all for me.
So if someone at 30, like this, comes to you, how do you broach what the future is going to be for like them, and what's the variance? Like, what do you say to somebody when you first start to see symptoms?
Well, it occurred to me when you mentioned the fatigue, I wanted to back up just because I know that in the MSK system, we actually haven't had the rheumatoid arthritis lecture yet. That's coming next week. So I just wanted to make sure that we all knew what we were even talking about. Rheumatoid arthritis is an autoimmune, inflammatory, systemic condition. So we use the word arthritis because it mainly affects the joints, but it actually can affect multiple systems in the body. And so as opposed to osteoarthritis, which is, I have a bad knee, I have a bad hip, this is going to be more systemic. So fatigue is a very big problem because the immune system, I like to kind of explain it to patients, it's revved up, but it's ineffective. And that revved up immune system can leave someone feeling wiped out. And so even when someone is quote unquote doing well from all of our parameters, they still can suffer from a lot of fatigue, and that can actually be very debilitating. So as far as the question of when we make a diagnosis of rheumatoid arthritis, what can we tell the patient? And what we tell the patient today is very different than probably what you might have heard 30 some years ago, because we have 15 new medications that are under the biologics that are new medications that have come out in the past 10, 12 years for rheumatoid arthritis and have really revolutionized the way that we treat. So yes, it's a chronic condition, and I make sure that that's understood, that I can't cure it, but we have a lot more tools to be able to treat it and help patients live as normally as we can.
You were talking about medication, because when I was diagnosed, they didn't have biologics. So they gave me steroids, massive injections of steroids, which now has given me osteoporosis. Not just now. I mean, I was diagnosed with osteoporosis in the early 2000s already. I started with Remicade, which is an infusion. You go for 8 hours and sit in the hospital. And then I had a horrible reaction. They told me never take this drug again. So then I went to Enbrel, and then Humira, and then Orencia, and now I'm on Rituxan. So I am very lucky that I have a lot of choices right now. If it doesn't work for me, they can switch it. Anyway. But also the medical field has changed so much. Like you were saying, you have patients you've had the whole time. Right now, the way insurance is, I've had about, 8 different rheumatologists. So,
and are they consistent in how they're treating you, or do you
No.
go to one?
Absolutely not. I've had doctors that basically come in with a graph telling me statistically what's going to happen to me. I didn't like that. And to the other side of the spectrum, the rheumatologist I have right now is super connected, and she sees me as a person, not just a number. And that means the world to me, So remember that with your patients.
So let's talk about your art a little bit.
Okay.
So tell us what's going on here, obviously body-based, and then so you can tell us what's going on, and then we'll have the doctor do her artistic critique, looking at it as a doctor doing a diagnosis, maybe.
This first panel here is called Tangled, and it reflects how I feel some days. All the frustration, so you kind of feel like you're just tangled, And it's done with acrylic, and it's on a really pristine white panel. So this was done early in my artistic career, so I had a little more flexibility with my hands back then. So I didn't even use a brush, basically, except for the hair. And the one directly behind me is called Twisted. Again, talking about just the struggles sometimes, they're, daily, and how the lack of control, I think. Really, as a patient, you feel this lack of control. You think you're invincible until something hits you, And then this final one is the most recent. It's a self-portrait. It's done in 2018, and it is called Counterpoised. So I'm kind of talking about this balancing act that I do every day. I'm balancing on the bones, and you have to make choices whether you want to take this drug or should I do this activity, And I have grandkids now, and they always ask me the funniest things, especially when they were little. They used to take my hands and they were so amazed, But that's basically what my work is about. And then I have the x-rays here. Mm-hmm. And that series is called Exposed, where I ordered all my x-rays and printed them out through the years so you could see the progression of the joint damage. And then on top of it, I dropped acrylic paint. And to me, that felt like how I feel about my disease and my joints and my bones. I have no control because I drop it onto that x-ray and I never knew where it was going to go, right? It had a life of its own at that point. So that's what the x-rays are about.
Okay, we'll talk about the other ones in a sec. So
okay.
You looking at these, so this is part of the reason we do this whole program is because I'm a strong, and Pam too, believer that good things, if you have an illness and you look at the whole person, good things can come out of it. Like this is artwork that would have never happened had she been healthy. But here we have this beautiful artwork that's up on the wall because she has this annoying illness. So think of that like when you see your patients. They're not just their symptoms. They are people who, as a result of their symptoms, can make really beautiful things. That said, what would you like to say about the art?
Well, I'm certainly not an art expert. The one thing that kept popping into my mind just looking at them and as you were talking is how much I've learned these conditions and rheumatoid arthritis affects the person just from talking to patients. Because in training and in textbooks, you read the symptoms. You read joint pain, you read stiffness, swelling, morning stiffness. But that feeling of being twisted, of feeling tangled, of feeling like your body is not your own, that your joints are not your own, the unpredictability of it, the feeling of betrayal, that your body has betrayed you, that it's no longer your own, I've learned from talking to patients. And I think that these depictions just clearly show that it's kind of, this twisted, tangled mess that's not your own and that you don't have control over. And when I immediately saw the x-rays walking down, of course I had to take a step back because my eyes go straight to the joints and straight like, oh, look at the arthritis. But then seeing the pain and again, the fact that you don't have control, I hear that every day. And part of what I see my job is to just kind of stand there with them and kind of acknowledge, yes, we don't have control and there's going to be bad days and rain's coming and how, try to help strategize how we can deal with that because we know from history and from that person's body what the arthritis can do. And a lot of it's just sitting there and being with them while they kind of express the frustration because it is any autoimmune condition where you have fatigue and you just don't feel like you have control over your own body. And then there was a point that you were making about how now because of this condition we have this art and it's similar to a point that I try to help patients see, and again, this is something I've learned just from seeing patients. when you have an autoimmune condition and you don't have control and you have a lot of fatigue, you are forced to really look inward and really get to know your own body. And you are forced to understand what your limitations are. And you're forced to understand how maybe different foods affect your body. And you just don't have a choice because your body's going to show you whether you want to or not. And I think a way of looking at it, because I don't have a cure and I can't make it go away, a way of looking at it is somewhat of a blessing that you understand your body probably a lot better than people who don't have any conditions and just kind of bull forward and work 100 hours a week and sleep 4 hours at night and eat bad. And then, those people are not doing their bodies any good either. But because their body is not talking to them the way an arthritis patient's body talks to them, they kind of just bull through until, it catches up to them much later. And so I think that trying to look through for silver linings in these conditions that it's like a roller coaster sometimes, similar to, well, we wouldn't have this art if it wasn't for this. I think you wouldn't be as in tune with what you need if it wasn't for this condition. That's what I always try to help people see.
It's true.
So let's talk about this other series up on the wall over here, the photos. What's going on there?
The photos I titled Double Trouble. It's interesting when you're making art, you may think you're doing it for one reason, or you have this objective thing you want the viewer to see. And then years later, you go back and you look at your work and maybe it's not about that, Because when I did this series of photographs, it was when I found out I had osteoporosis. My hips were going. And the doctors wanted to put me on these strong medications. And I was scared of all the side effects, So I was thinking, I can take these powerful drugs and do what I want to do and finish school and, be semi-normal, or I can not take them and not have those side effects. So that's basically what I was thinking. But as I got this work out and re-looked at it, it's basically it's my future. I mean, it could be me back then versus me in 20 years, the whole idea of what I think where I'll be in 20 years is not what it was before I got RA. Right? So that's what it's about for me anyway. Does anybody see something different? I always like to hear different points of view. No?
We're going to have a special guest.
So it just so happens that one of my colleagues, professor and chair of the Department of Pathology, Dr. Michael Selstead, is here. His research is on rheumatoid arthritis, and I'd love him to talk about some of the new options that may be coming down the road.
Thank you very much. First of all, thank you. And I have a question.
Okay.
What are the challenges of generating a piece of art this large when you have joints that are impeding your movement?
It's called a studio assistant. Can you lift this, move that? She did all the heavy work, and I appreciate her. She is fabulous.
It's impressive, and the themes are very obvious. So I haven't met most of you. Thank you, Dr. Schaff, for inviting me to say a few words. I actually met Ted in this very setting 2 years ago when we had the first, what was it called? Artisan Researchers. And so Ted actually was putting together pairs of artists and researchers who had never met each other. And then in my case, I had one meeting with a really talented, what do you call the work that?
Well, he made a three-dimensional piece. He calls himself a thing maker. He doesn't do.
So he made a thing out of the concept of what I'm going to just tell you spend a couple of minutes telling you about, which is my research, which is completely focused on RA. So I have an appreciation for the disease because my father had a very unusual form of RA, and it's genetically transmitted. His sister has exactly the same version, painless, but very substantial joint erosion. And then I happen to also have a total knee replacement. So I have an appreciation for, that's OA. I have an appreciation for how much this technology can help us get on with our lives. So the research that I've been doing led us to a new treatment for arthritis completely serendipitously. I have been studying for almost 30 years the innate immune system in humans and other mammals, and about 15 years ago discovered that rhesus monkeys, white blood cells, produce a very unique small protein. It's actually a peptide that those of you who are now medical students will understand is unusual if I tell you that it is completely cyclized on itself. It's completely circular structure, little tiny molecule. We name them theta defensins. This is back in 2000. Subsequently, we discovered, these were molecules sort of in search of a function, but we had discovered them based on the fact that they suppressed over-revved immune systems in animal models. And so we hypothesized that a molecule that does this in a rhesus monkey, first of all, that it would be certainly produced in humans. We're 98% identical genetically to rhesus monkeys. And it turns out that humans don't make this molecule. And so during evolution, the expression of these cyclic theta defensin peptides ceased for reasons that we don't quite understand, but they're not made in New World monkeys or chimpanzees or great apes, gorillas, or humans. But they are made in rhesus monkeys and baboons and cynomolgus monkeys today, and they make huge amounts of them. Coincidentally, rhesus monkeys and other old world monkeys don't get rheumatoid arthritis. So we hypothesized that these molecules actually might be innate regulators of inflammation that would otherwise allow for dysregulated joint inflammation and destruction. So we began a number of studies with rodent models of rheumatoid arthritis and showed that we could actually arrest the evolving disease in animals that already had induced arthritis, and in fact get it to resolve in literally a period of 2 weeks. We published this work about a year ago, and in parallel hypothesized that this might be a drug that we could actually use to treat individuals. And so we went through the whole process of figuring out how to make large amounts of a molecule that's naturally made in a monkey for use potentially in a human. Went through a multi-year process of doing all the safety studies in animals. And the idea is that this molecule, because of the way it naturally acts, could conceivably alter the course of disease in rheumatoid arthritis and potentially other autoimmune diseases without the side effects. The reason being that this is a naturally occurring molecule that monkeys are making at huge concentrations all the time. We've shown that they have a very good safety profile. So we took a leap of faith and with some friends and family money, started a little virtual startup company to try to test whether or not a molecule like this that's in a monkey could be used to treat a human disease. We received notice 10 days ago from the FDA that the clinical trial has been approved to proceed.
Wow.
So this is my first rodeo and the first example of a peptide to be used for an autoimmune disease. And the hope is, of course, that this is something that can be used safely, long-term, without the side effects, and would have anywhere close to the therapeutic efficacy that you've seen with some of the drugs that you're using in Rituxan currently.
Mm-hmm.
Right. So anyway, it's a delight to have you here, to share your art, your experience, and we got something for you.
Yeah, thank you for all your effort and hard work.
We have about 10 minutes, so.
Okay. Yeah, one more question for the doctor. And if you guys want a monkey, he's got an office full of monkeys for you. So when you came in, you said you looked at the x-rays, but then did you look at them as art, or did you immediately just go to the joints? Because they're obviously been manipulated.
I mean, obviously, I knew I was walking into an art exhibit. I could see that they were art, but I'm just so trained to look at them as x-rays that my first view is just looking at the joints and looking at some of the progression. I immediately saw the implants and the digits, and my first thought was like, oh wow, like just because I'm a rheumatologist and this is what I do every day. But then I took a step back and was able to kind of just appreciate it as art.
Does anybody have any questions for anybody on our panel of the three?
I have a question for my own sister.
Okay.
So from afar, because we're not neighbors, I've seen the progression and the things that have happened to you over time. But you've always shown such strength, amazing resilience, because I probably don't see you in the weakest times. But can you kind of describe to the group here how you continue to teach art at the college level? I'm not sure that's really been talked about, and I wanted you to express some of your thoughts on that and your continued effort there. Thanks, Elaine.
Well, I love teaching, and I've been doing it for about 13 years at community college level. And art, I love art, so it's the perfect world for me. And because I'm an adjunct instructor, I don't have a full load. Unfortunately, this term I did get very close to a full load. But normally I have 2 classes, so I'm able to function within those. I know any of you teachers have a lot to do even outside the classroom, right? So it's not just the time they're in the classroom. But I don't know, I guess it's because I love it so much. It keeps me going, and I hope to be teaching until I'm at least 67, so I still have 5 or 6 years to go.
Do you think the subject of your work makes your students more likely to do work that's important or internal rather than a landscape or a flower? Or
I would hope so. I would hope it would direct them that way. I think most art is strongest when it's talking about something that really touches home with them, right?
I'm curious how you speak with your students about your diagnosis. Is it the elephant in the room, or do you talk about how you manage or how you're going to change your work schedule?
Well, it's an interesting question. I usually don't say anything, but I had a major flare at the beginning of the year, and I still taught, but I could barely get out of my chair, and it was very obvious. So I basically had to say something. I couldn't just push it under the rug. And they're very supportive and understanding. you know, they help me. Do you want me to move this for you, Miss Johnson? You know, I really appreciate that, you know. So, yeah.
So, childhood arthritis. Parents come in with their kids. That's a whole different way of having to bring up a subject when somebody's kid's suffering. So why don't you talk for these guys a little bit about how you would talk to a parent that their child's being diagnosed versus an adult being diagnosed?
Oh, yeah, that's a whole other topic. So just like adults, kids can get inflammatory arthritis. We call it juvenile idiopathic arthritis, and it's like a cousin to rheumatoid arthritis. Very similar symptoms a lot of times, but can behave and respond to treatment a little differently. About 50% of kids who are diagnosed with JIA actually will we call it outgrow it, or it'll go into remission, drug-free remission into adulthood. That means 50% of them will continue to have arthritis into adulthood and behave very similar to an adult with rheumatoid arthritis and kind of have a chronic condition. To be fair, I am not a pediatrician. I'm a trained internist, so I'm not often there for those initial diagnoses, but I do take care of a lot of adults who are diagnosed with JIA as kids, and now they are 21, 22 and have to see an adult doctor. It can be very, very challenging. I think that obviously parents are very scared and worried for their children. What does the future look like? And then we have all these brand new medications, and from the doctor's perspective, they're great and that they control the disease. But from a parent's perspective and a child's perspective, the question always is, well, what does this mean? I'm going to be on this for the rest of my life, and I'm 10 years old. So what does that mean? I'm going to be on these medicines for 70 plus years. And so that's, again, some anxiety that we have to work through together. And even those conversations that happen as kids, when they grow up and now they're on their own and they're coming to see their doctor without their parents, we kind of revisit all of those same discussions because the patient wants to have those discussions now as an adult and make decisions on their own. So it can be difficult, and helping them understand how they're going to fit in, because if they start having joint changes, you know, when you're a teenager, fitting in with your peers is huge. It can have a huge impact on self-esteem. If they have to be on steroids, like she mentioned, steroids, they just have horrible side effects. They can change your appearance. You can gain weight. You get swollen from water retention. And again, when you are 13, 14, 15, and you're in high school and all you want to do is fit in, those things can be really difficult. And so my experience more is actually dealing with the aftermath of that, and they're in their young 20s, and they might have some self-esteem issues, some anxiety related to kind of what they've been through as teenagers.
My question is for the doctor. I think it's fabulous that you want to help your patients see the present in the teeth of the dragon. I'm thinking that also there could be a great potential for backfiring as you try to go down that path, and I'm wondering if you would comment about how often you feel you're successful, and if and when it backfires, or how often it backfires for you.
As far as trying to help them see positives, or?
Yeah, that something good could come from this.
Yeah. Again, I see patients with rheumatoid arthritis and other inflammatory conditions once a month. So I'm seeing them pretty regularly, and part of my field and part of what would make a good rheumatologist is being open to and having open discussion with the patients. And so I always really try to make sure that if what we've been talking about doesn't sit well, that they feel comfortable bringing that up. I honestly don't have very much pushback. That being said, I'm a huge fan of getting second opinions. And if a patient and I are not clicking, or they don't agree with my approach, and they want to have a second opinion, then I'm a big fan of going and getting that second opinion, because part of what makes treatment with rheumatoid arthritis successful is trust in that relationship. And so the patient needs to feel like they can trust their doctor. And there's tons of things that might influence that relationship. And so I say I don't have that much pushback, but it might be that the people who didn't appreciate that point of view might have found another rheumatologist that was more in line with the way they wanted to approach things.
Is that something you would try early on in your treatment, like first visit, or would you wait to?
Oh no, that's something that I wait. Like that's something that when we're on a steady treatment and from my parameters things look to be okay, but the patient's still struggling, and there are other, there's a lot of data that shows that for rheumatologists and rheumatoid arthritis, we have certain parameters that we follow that tell us if the patient's doing well or the patient's not doing well. We check labs, we check inflammatory markers like SED rate and CRP, we do x-rays, we do our physical exam, and based on those parameters, a doctor might tell a patient, you're in remission. But it's very well documented that sometimes what the doctor says is very different than how the patient feels. And the patient might still say that they're struggling, they have a lot of fatigue, they're still stiff in the morning, and there's a disconnect. And that disconnect in my field, we're not very good at bridging that. When I get in those situations is where sometimes I bring in some of these other thoughts, because as far as medications go, I don't have a lot of medications that help bridge that gap.
Can I ask a quick question? I fight anemia, and is it because the RA blocks the absorption of it, or some other reason, the medications or?
Well, so it's very common to have what we call anemia of chronic disease when you have autoimmune diseases or inflammatory diseases. And when someone is persistently anemic, it most likely, and of course every case is different, but it most likely means that there is a low level of inflammation that's still occurring. And so again, we try our best to control it as best we can, and we are, and these days, pushing for remission of rheumatoid arthritis. Only about 10 to 15% of patients can actually achieve remission. And so the second best would be disease of low activity. But even disease of low activity might still have some inflammation that would result in some anemia. So you do your best to make sure the patient's optimized with all their iron and with vitamins and kind of approaching it from all angles to make sure that we're doing the best to optimize the patient, but there still might be some anemia.
All right, we're going to finish up. I just want to remind everybody, or just tell you, that the back wall is usually student and faculty art, and we have a call for each one of these shows about 3 weeks or a month before the show goes up. So if you are an artist and you do work about the subject, the next artist has MS. So if there's anything that would relate to that, we would love to have your work here. And I'm going to leave it to Pam to close it up.
Just with respect to the call for art, it'll be anything in the neurosciences system, so think about that. I said at the beginning that the purpose of these exhibits is to foster enhanced understanding of, between patients and their future health professionals, but I also want to say it fosters inspiration, and I want to thank you because I think you inspire us, our students, to study and learn so we can take care of our patients. And obviously you inspire researchers to do work that may eventually find a cure. So thank you for your generosity.